Hello, Assalamu alaikum. Today I would like to discuss about mm, some obstetrics and gynecology topics. Start with this disorders of sex development. Along with I will go through some of the things like some topics regarding CSF forms. Okay, these are the disorders of the sex development. In disorders of the sex development, what we have to remember: androgen insensitivity syndrome, AIS. The things we need to remember: first, we need to go to bar first, like breast development, axillary and pubic hair development, and reproductive organs. In androgen insensitivity syndrome, the bar breast development, yes, axillary and pubic hair mild to absent, so absent. And the reproductive one, in the reproductive there is absent uterus and upper vagina, absent uterus and upper vagina. But in androgen sensitivity syndrome, as its karyotype is XY, so there are some form of testis present, so there is cryptorchid testes. So, for androgen sensitivity syndrome, there is X-linked mutation of the androgen receptor. There is mutation A for androgen receptor. So, I wanna discuss this topic again. Like, if you find a case of androgen insensitivity syndrome, go for the bar, breast development, uh, axillary pubic hair, and reproductive one. In androgen insensitivity syndrome, breast development, yes, there is absent or minimal axillary hair or pubic hair. In the reproductive organ, there is absent uterus, upper vagina, but as the karyotype is XY, so there are some form of testes which is cryptorchid testis. Now next one, for Mullerian agenesis, MA, like for Mullerian agenesis, what happens in the Mullerian agenesis? In Mullerian agenesis, breast development, yes. Axillary pubic hair, normal or yes, normal. And reproductive organ in Mullerian agenesis, also known as Mayer-Rokitansky-Kuster-Hauser syndrome. In here, the reproductive organs like absent uterus, upper vagina, but normal ovaries. In here, normal ovaries. In Mullerian agenesis, there is normal ovaries and the karyotype is XX. So it's female. So she has normal ovary but absent uterus, upper vagina. Okay, then the next. Transvaginal, transverse vaginal septum. In transverse vaginal septum, again, breast development, yes, pelvic or axillary and normal. Transverse vaginal septum, there is normal uterus, abnormal vagina, but so transverse vaginal septum problem in the vaginal, abnormal of vagina, and the uterus and the ovary is normal, and it is also 46XX. And the last one, the Turner, turns into female, like 45XO. In Turner syndrome, there is 45XO, 45XO. So there is complete or partial absence of one X chromosome. In here, breast development is variable, normal, uterus, vagina, but in reproductive streak ovaries, streak ovaries. In transverse vaginal septum, there is abnormal vagina, but normal uterus, ovaries. In Turner syndrome, axillary and pubic hair is normal. It is 45XO. So that's all about the disorder of sexual development. This is a very high yield topic. Need to remember for the upcoming exam. Now, Turner syndrome. In Turner syndrome, there are multiple systems can involve like cardiovascular system, renal system, MSK system, vision and hearing, autoimmune. Cardiovascular system, there is congenital heart block, for extremity BP, ECG, and echocardiogram should be done. Aortic dilatation or dissection, transthoracic echo or cardiac MRI should be done. And the metabolic syndrome, BP, HbA1c, lipid panel, and liver function test should be done. In renal, horseshoe-shaped kidney renal ultrasound, horseshoe-shaped kidney renal ultrasound. In MSK, there is osteoporosis, 25 hydroxy vitamin D level, and DHA scan and DXA scan, DEXA scan, and vision and hearing like strabismus and myopia. There is ophthalmology evaluation, recurrent otitis media, hearing loss, audiology testing, and in autoimmune like celiac disease, tissue transglutaminase antibody and hypothyroidism TSH FT4. TSH FT4 should be done. And there may be aortic coarctation and bicuspid aortic valve. There may be aortic coarctation and bicuspid aortic valve. There is a high risk in pregnancy, but pregnancy can be um, happen by IVF. If you do in vitro fertilization, then pregnancy maybe happen in Turner syndrome. Okay, now this is a picture of the Turner syndrome. There is short stature, narrow, high arch palate, narrow, high arch palate. There is low hairline, web neck, broad chest, wide space nipple, cubitus valgus, shortened fourth metacarpal. There will be coarctation of the aortic dissection by gastric aortic valve or shaped kidney, streak, ovaries. All patients with Turner syndrome require screening for cardiac disease with four extremity blood pressure, ECG and imaging, echocardiography and cardiac MRI. If aortic dilatation is suspected, beta blocker and aggressive blood pressure control are indicated, and surgical repair may be considered based on aortic size and risk factor. Maybe aortic size and risk factor. Okay, look at this question. Like a 32-year-old primate woman comes to the physician 30 weeks of gestation because of 10-day history of 30 weeks of gestation, because of 10-day history of decreased appetite, intermittent nausea, generalized itching, and she has a history of non-serious illness, pulse normal, blood pressure slightly low. There are some excoriation on the left shoulder. There are some excoriation on the left shoulder. The lungs are clear to auscultation. There are a 2 by 6 systolic murmur is heard on the. There is 2 by 6. The uterus is consistent in size in 30 weeks of gestation. Hemoglobin 11 mcv 86, leukocyte count 10,000, platelet count 1,14,000. So platelet is slightly low. There is total bilirubin slightly high, not that high actually, but ALP is higher. ALP is slightly high. Abdominal ultrasonography shows no abnormality. Which of the following is likely? to explain her symptoms. So she's 30 weeks of gestation, just slightly low platelet count, um, but ASTL, DLP that not that high. Actually normal. In HELP syndrome, there is hemolysis, elevated liver enzyme, low platelet. There is no elevated liver enzyme. There is no signs of hemolysis. Just there is uh, intermittent nausea and generalized itching. There are some excoriation. In acute fatty liver, there may be again all the liver function should be higher. It may be either normal pregnancy or intrahepatic cholestasis. 30 weeks gestation, slightly low platelet. ALP is not that high. There are examinations show excoriation of the left shoulder. The uterus is normal. I think it's an feature of normal pregnancy. Either it's normal pregnancy or intrahepatic cholestasis. I think it's normal pregnancy. Okay, next question. 21-year-old woman comes to the physician because of 2 week history of small amount of 2 week history of small amount of vaginal discharge and itching. So she has vaginal discharge, she has itching, her symptoms begin immediately before her last menstrual period. No she has had two sexual partner over past 2 months and uses oral contraceptive. 1 month ago she had a pain on urination in her frequency that result after 7-day course of cephalexin. Urine frequency has declined after 7-day course, so he has some sort of UTI, I think so. Okay, examinations show red introitus in the vulva. There is red introitus vulva. pH is more than 4.5. pH 4.5. There are two indication. It may be trichomonas. It may be bacterial vaginosis. But in bacterial vaginosis, there is no bacterial vaginosis, Gardnerella vaginalis. There is no, and the KOH preparation dishes produce no odor. KOH preparation, wet mount preparation, no motile organism. Wet mount shows no motile organism. So red introitus vulva pH is vaginal pH is more than 4.5. Vaginal pH more than 4.5. There are two. It may be Trichomonas vaginalis. It may be Gardnerella vaginalis. Trichomonas vaginalis. There is inflammation. Red introitus. Um, and the KOH discharge, the additional KOH to the discharge produce no odor. A wet mount preparation show no motile organism. No motile organism. Which of the following is most likely that pH is more than 4.5? There is red introitus. That means inflammation is present. I think that it's a Trichomonas vaginalis. There is itching also. So it may be. Okay, next. A 50-year-old woman, gravida 3, para 2, about a 1, about a 1 has loss of urine with loss, she has loss of urine and loss of urine and coughing or straining like stress incontinence and lifting since 9 years ago. Her child, so he has a loss of urine, coughing, straining, lifting since the birth of the last child of 9 years ago. Symptoms progressively worsened over the past 2 years. During the examination, she loses urine in some small spurts in coughing, but anterior and posterior vaginal wall appears supported. A cotton-tipped obligator placed in the urethra moves in the area of 45 degree in a horizontal Valsalva maneuver. A cotton-tipped applicator is placed in the urethra moves in an arch of 45 degree with horizontal and Valsalva maneuver. Which of the following is the most likely diagnosis? Anteroposterior vaginal wall are well supported, but she has some sort of urine coming through stressing. So I think uh, it's cystosil. Okay, the 14. A 42-year-old woman instantly comes to the physician for a follow-up of examination. 2 weeks ago, the prednisolone therapy was began. Prednisolone began ASLE. Prednisolone given for a flare of disease. This is our third course of prednisolone during the past 18 months today. The patient is feeling well. Men's Walker, her only other medication, vitamin D and calcium. She has no other history of serious illness, and there is no family history of serious illness. He has no allergy. She does not smoke cigarettes, drink alcohol. She is 5 feet 5 inches. BMI is 23, pulse is 70, blood pressure 108 by 64. Examination shows no abnormality. Which of the following is the most appropriate pharmacotherapy to prevent osteoporosis now? So, hmm, SLE given prednisolone, although alendronate can be given. SLE patient osteoporosis, taking prolonged, so alendronate can be given. Okay, the 15. 47-year-old Naligarvid woman comes to the physician because of heavy menstrual flow during the past 3 months. Previous months were normal. She has had mild hypertension. She has had mild hypertension treated with diuretics. mm, Type 2 diabetes mellitus treated with oral hypoglycemic. She has no she has no history of PAP. Physical examination is normal. A pap smear is reported with atypical glandular cell. Pap smear show atypical glandular cell. Colposcopy shows no abnormal. Endocervical curettage show benign cell. Endocervical curettage show benign cell. Which of the following is the most likely diagnosis? Atypical glandular cell. Mm, Endocervical curettage show benign cell. So what may be that done? So it's not so it might be lip. Okay. Okay, only one question is right. So it's a poor performance. Like in this question, uh, like this, the answer is the endometrial biopsy. Okay, why it's endometrial biopsy? We need to discuss about this. We know that a BAP shows BAP smear is reported an atypical glandular cell and colposcopy show no abnormality, and endocervical curettage shows um, benign cell. So what we need to do? We need to do endometrial biopsy in abnormal uterine bleeding like this 47-year-old newly gravid woman. Abnormal uterine bleeding should be suspected when bleeding is irregular, unpredictable, and not associated with usual menstrual signs and symptoms. Usual menstrual signs and symptoms: bloating, breastfulness, uterine cramps. It may be caused by structural abnormalities such as cervical or endometrial polyps, adenomyosis, endometrial hyperplasia, malignancy, and inflammation or infection of the genital tract, coagulopathy, ovulatory dysfunction, or endocrine dysfunction like thyroid disorder, prolactin, and estrogen. It may also be iatrogenic or idiopathic. The patient has no symptoms or no history of thyroid disorder, coagulopathy, polycystic ovarian syndrome, or other ovulatory function. In patients over 45 years of age, there is higher risk of in patients with 45-year risk, there is higher risk of endometrial hyperplasia and malignancy. So this patient with atypical glandular cells. So patients with atypical glandular cell on pap smear has been evaluated for cervical malignancy with colposcopy and endocervical curettage, which showed no abnormality. The next step in evaluation would be endometrial biopsy to evaluate the risk of endometrial cancer. If a patient cannot tolerate an outpatient procedure, the inpatient if the patient sampling is non-diagnostic, DNC, dilatation curettage, or hysteroscopy can be performed. A hysteroscopy with sampling allows for a more complete evaluation of the endometrium like polyp, myoma, and structural abnormality. Endometrial polyp, myoma, and abnormality. Why it is not lip? Lip is excision for cervical transition zone would be done if colposcopy or endocervical curettage show cervical cause on atypical pap smear findings. So lip done when if colposcopy or endocervical curettage has some sort of problem, then we do lip. So abnormal uterine bleeding caused by structural neoplastic coagulopathic infectious endocrine and iatrogenic causes or after an abnormal pap smear showing after an abnormal pap smear after an abnormal pap smear showing atypical glandular cell, the next appropriate steps in evaluation includes colposcopy and endocervical curettage. If these are normal, an endometrial biopsy is necessary. If this is normal, an endometrial biopsy is necessary to evaluate for endometrial hyperplasia or malignancy. So this one, we know that glucocorticoid can cause osteoporosis. Glucocorticoid significantly alter the calcium metabolism by decreasing the GI absorption, enhancing osteoclastogenesis, and inhibiting osteoclast differentiation. Primary prevention of osteoporosis is indicated in patients with chronic low corticoid use to prevent premature or pathology. Fragility, fracture, vitamin D and calcium are recommended for all patients are low risk fracture. In addition to calcium or vitamin D, patients at moderate to high risk fracture are also treated for oral bisphosphonate and alendronate. Bisphosphonate have been shown to reduce fracture risk and increase bone density. They are mainstay of osteoporosis treatment and prevention in patients that are moderate to high risk for BMD because of corticosteroid use. Bisphosphonates act to inhibit the action of the osteoclast, thereby preventing the bone loss, thereby preventing the bone. So, Alan Donald, I got right this question. This is right, but I got wrong too. This is the answer. This would be urethrosil. Why it is urethrosil? Because anterior and posterior vaginal anterior wall is cystocele, posterior is rectocele, anterior posterior is normal. This is stress urinary continence. I know that. And in multiplex woman, sorry, multiple pregnancy with the resultant mechanical stress on the vaginal wall. In the vaginal wall and the pelvic floor can cause weakening of the muscle and connective tissue. Weakening of muscle and the connective tissue. This weakness in turn compromises the support of the pelvic structure, including the uterus, bladder, urethra, rectum. A urethrosil occurs when urethra prolapses into the intervaginal wall or out of the urethral opening itself due to loss of proximal support, increase abdominal pressure causing vesico-urethral junction to move out of the place and preventing sphincter closure with subsequent leakage of the urine. It is associated with urethral hypermobility as evidenced by deviation greater than 30 degree. It is deviated greater than 30 degree. It is deviated greater than 30 degree from the horizontal and inserted cotton tipped applicator with straining. It can occur alone or in conjunction with cystocele, which is a common cause of stress in urinary incontinence. So urethral can occur alone or can occur in conjunction with cystocele. Like Hmm, common cause of stress incontinence. This is a common cause of stress incontinence. So this one, it is associated with urethral hypermobility as evidenced by deviation greater than 30 degree from the horizontal and an inserted cotton tipped applicator with straining. Okay, urethrosil now candida albicans. This is a very fishy question. Like there is pruritus vulvar erythema, so over pruritus there is inflammation, and KOE show vulvovaginitis, and KOS testing show there is vulvovaginitis from Candida albicans. When Candida, why it is not trichomonas? Trichomonas is flagellated protozoan that can cause vaginal trichomonasis. Trichomonasis pruritus, dysuria, dyspnea, cervical erythema, and abnormal that is described by green frothy maluterus. Vaginal pH is often increased over 4.5. Motile trichomonad can be visual on wet mount. Okay, it's non-normal pregnancy. It's intrahepatic cholestasis. Why it is non-normal pregnancy? Normal pregnancy is not characterized by pruritus or nausea in the third trimester. Though nausea in early pregnancy is common, the patient has atypically high bilirubin concentration. In normal pregnancy, maternal LPase activity can be increased by placental lysoenzyme activity. Additional plasma volume increases in late pregnancy, resulting in systolic flow murmur and dilutional thrombocytopenia and anemia. So intrahepatic cholestasis is also known as cholestasis of the pregnancy, a common liver disease. It is typically occurs in the late second or third trimester. In the late second or third trimester quickly resolves following delivery, rising estrogen and progesterone concentration in addition to potential genetic susceptibility are hypothesized results in impaired of bile flow. Patient typically presents with generalized pruritus and can be exhibit right upper quadrant nausea, this and that. Okay, this is help. And okay, that's it. So that's all about the disorders of sexual development and some five questions. Hope you enjoyed.